Hello, my name's Ashley Carr, and I'm going to be doing a case study on a patient that presents with urinary incontinence. Urinary incontinence is defined by the Agency for Healthcare Research and Quality as the unintentional loss of urine. Acute urinary incontinence is generally a result of illness or the effects of medication, and once the underlying cause is determined, is self-limiting. There are four types of chronic urinary incontinence. Stress incontinence, which is a loss of urine with maneuvers such as coughing or laughing. It's usually related to weak pelvic floor support and an increased intra-abdominal pressure. Urge incontinence is associated with frequency, urgency, nocturia, and it's usually related to the detrusor muscle instability. Overflow incontinence is overdistension and incomplete emptying of the bladder. There's constant dribbling, frequency, hesitation when initiating urination, nocturia, and it's associated with a bladder outlet obstruction, such as BPH in men or pelvic organ prolapse in women. Functional urinary incontinence is related to factors unrelated to the urinary tract, such as a cognitive impairment or immobility. Urinary incontinence is twice as prevalent in women, and advancing age is the largest predictor. Risk factors include history of pregnancy and or hysterectomy, heart disease, stroke, diabetes type 2, arthritis, obesity, lack of education. Why is this significant to nursing? A patient who suffers from urinary incontinence oftentimes is socially isolated. They feel lonely. It's difficult to work and perform your duties at work, so they leave. And it's also an economic burden for both the individual and society. The estimated total annual cost in the US for urge incontinence is $82.6 billion in 2020. Our patient is a 66-year-old Caucasian female who lives with her spouse of 48 years and reports feeling safe in that environment. She is allergic to sulfa and she has seasonal allergies and no reported food allergies. All childhood immunizations are up to date, including her pneumococcal and her shingles vaccination. She had her vision, dental, mammogram, and annual physical exam in 2018, as well as her colonoscopy in 2016 and DEXA scan in 2017. She has a history of hypertension, hyperlipidemia, mixed connective tissue disorder, and seasonal allergies. She's had multiple surgeries in the past. The patient often will not complain of urinary incontinence because he or she feels it's a normal part of aging. So it is very important that as a provider, we ask the patient urinary symptoms. And if they respond positively to an answer, yes, I am having urgency, or I'm getting up a lot at night and going to the bathroom, we must go delve deeper into that to determine the type of incontinence that he or she may have. The presentation can vary depending on the cause. So when we're collecting a history, we should include bowel habits, medications they're taking, any medical, surgical, genitourinary history, history of pelvic trauma, neurological issues, and then we need to do a detailed review of symptoms related to the incontinence. Most significantly, the patient denies difficulty urinating, dysuria, hematuria, nocturia, urinary hesitancy, any odor to the urine, or any pelvic trauma. She does complain of urinary urgency with urinary dribbling and loss of urine with sneezing, coughing, and laughing. She denies any back pain, any any dysfunction in her extremities, muscle weakness, numbness, tingling, denies headache, behavior changes, depression, anxiety, nervousness, sleep disturbances, denies fever, fatigue, chest pain, palpitations, any swelling or edema. On her physical assessment, she does appear well nourished. She's alert. She is well groomed. A regular rate and rhythm. There's no murmurs, rubs, or gallops. Her breath sounds are clear. There's no adventitious breath sounds, non-labored breathing. There is no CVA tenderness. She does not complain of bladder tenderness on palpation. Her bladder does not feel distended. Her pelvic exam, she deferred that. She declined to have that in the office. She does have full range of motion, a steady gait. She ambulates unassisted. She's alert and oriented. She follows commands. Motor and sensory function are within normal limits. Her mood and affect are appropriate. Her thoughts are logical. She has clear articulation of speech. The 4 screening tools that we chose to use on this patient include the CATS ADLs, which this one assesses the patient's ability in bathing, dressing, toileting, transferring, continence, and feeding independently. We chose the Geriatric Depression Scale. When you have urinary incontinence, it's not uncommon to suffer from depression, so we wanted to assess that in the patient. And then the Get Up and Go test and the Tenetti Gait and Balance Scale are both used to determine her mobility, to determine if her urinary incontinence is functional. She's unable to get to the bathroom. She's unable to pull her underwear down to urinate. So those 2 tests were used to assess her gait, her balance, and her risk for falls. Diagnostics and labs appropriate for urinary incontinence. The first thing that you're going to do is a urine analysis. You want to rule out a UTI. You want to check for hematuria, glucose, protein in the urine. And if you do have an abnormal urine analysis, you want to do a culture and sensitivity to ensure that the treatment is appropriate. If you think that there is renal involvement, you want to check the BUN and creatinine to evaluate the renal function. And if you suspect that there is polyuria, you want to check a serum glucose and calcium. Another test you can do is the post-void residual, and it's to exclude incomplete emptying, and you can either do a pelvic ultrasound or a catheterization. The pelvic ultrasound is the preference, and any residual over 100 ml requires further evaluation. My final diagnosis for this patient is mixed incontinence. Mixed incontinence is a loss of urine from both stress and urge incontinence. She states she dribbles when she laughs, coughs, and sneezes, which is stress incontinence, but she also experiences a sudden compelling desire to urinate that's difficult to delay, which is urge incontinence. She does have a history of 2 extensive pelvic reconstructive surgeries, placing her at a higher risk for urinary incontinence. For all types of urinary incontinence, the first line treatment is lifestyle changes. We want the patient to lose weight. We can also encourage bladder diaries where you're marking your fluid intake, your leakage, the voids that you're having, and we educate the patient to decrease fluid intake before bedtime and reduce caffeine intake. Constipation, fecal impaction can contribute to urinary incontinence, so you want to aggressively correct constipation. You can use the polyethylene glycol, increase the fluid intake, try to decrease medications that are known to lead to constipation. We also can educate the patient on utilizing pelvic floor muscle training, also known as Kegel exercises. And you do 8 contractions 3 times a day for at least 3 months. And we could even refer the patient to a physical therapist to ensure that she is doing it appropriately. bladder training, where you do scheduled voiding and you suppress the urge between voids and just train the bladder. Now, a second line treatment for urge incontinence is oxybutynin 5 to 30 milligrams per day. Differential diagnoses chosen for this patient scenario. First is urinary tract infection. We can rule that out in this patient because she is not having dysuria, hematuria, she does not have an odor in the urine, there's no fever, there's no abdominal pain, and there's no CVA tenderness. A urine analysis would be negative for pyuria, bacteria, or hematuria. You could also rule out interstitial cystitis without hematuria. Again, the urine analysis would indicate if there's hematuria. But she is not having pain with a full bladder that resolves when the bladder is empty. She's not having nocturia. She's not having painful sexual intercourse. She's not having any sleep disturbances. And lastly, a differential would be disorientation. And that's ruled out because she does not have an altered mental status. She has a normal level of consciousness. She does not have impaired attention, and her mood and affect are appropriate to the situation. Barriers to my treatment plan. The patient refused a pelvic examination at the office, and a pelvic examination may reveal poor hygiene, skin breakdown from urine soaking, redness or thinning of the tissue, which is typical for atrophic changes. And it could also reveal a prolapse of any of the genitourinary structures or the rectum. And then if she goes to the second line of treatment and starts oxybutynin, placing an older adult on an anticholinergic agent, it has adverse side effects: constipation, blurred vision, cognitive changes, and the nurse practitioner must consider potential interactions with other prescribed medications in all adult patients. If behavioral interventions and medication management are unsuccessful and the symptoms are affecting the quality of life, we need to consider a referral. We could do a consultation with a multidisciplinary health team, and the team members may include physical therapy, a continence nurse, urologist, urogynecologist, or a specialized nurse practitioner. This is a compliant patient with her recommended preventative health services. She's knowledgeable of her current chronic health conditions. Has a steady income with stable employment, strong family friend support system, commercial health insurance, high school education, reliable transportation, and access to healthy eating options. Socioeconomic and ethical issues that may arise with patients who suffer from urinary incontinence. Lack of healthcare resources for the poor, the high cost of medications for chronic illnesses, and family and caregiver support. As a nurse practitioner, we must collaborate with the patient to develop a treatment plan that's obtainable, set realistic goals, and we have to acknowledge the patient's personal views of health, and we need to develop a trusting relationship between the provider and the patient, which will improve patient outcomes because the patient is more likely to trust us. In conclusion, we must educate our patient. Urinary incontinence is not a normal part of aging. It is a treatable medical problem. We must ask the patient questions regarding urinary symptoms and further investigate yes responses. In the older adult population, functional assessment is essential, and it may reveal the underlying cause of urinary incontinence if the patient is immobile, the dexterity. And lastly, patient education is important. We need to teach signs of infection, adequate fluid intake, prevention of constipation, and proper perineal hygiene.